I'm going to share my screen. First of all, thank you very much for inviting me. So we'll just get it up. So yeah, so I'm going to be talking about pragmatic use of AI with big healthcare data, and I'm an academic based in Leeds, but I'm also a clinician, and I'm certainly not an AI expert, data scientist or a statistician. I class myself as an end user of data, and I'm a psychiatrist. So if any of you feel a bit exhausted or sad or kind of a bit anxious at the end of this talk, feel free to give me a ring, because that's probably my area of expertise. But I have got quite a lot of experience in conducting randomized controlled trials, and some experience of large data projects in the field of mental health. So I think from my perspective as an end user, I think interventions have very good internal validity, but always they fall down in terms of external biases because of the selective nature of consent processes. And particularly in mental health, it's always the case that the most severely ill people, the most socially disadvantaged people, are exactly the people who do not get access to trials. And I think some of the large data banks as well, which require consent, although they have large numbers, they suffer from similar kinds of problems with external validity. And again, the kinds of people that I see in my clinic are not really like the kind of worried well of New York that go in to see a psychiatrist. They're very much people at the lower ends of society with very little resources, who are very unlikely to participate in conventional studies. So this means that we're excluding quite a very important group from research. And of course, large data and AI have the potential to address many of these biases that are inherent in data that require consent for collection. Now, there is an advantage to data that requires consent to collection, because you know what you're getting. It's very systematized, and it's often very detailed. So there are pluses as well as minuses. And I see kind of the different methodologies kind of dovetailing to support each other rather than being in any way antagonistic. But certainly our experience in Leeds and other people's experience is that the business of accessing large data, particularly trying to link data from different data sets, is, I quote, incredibly complex, arduous, slow, and stifles innovation and delays scientific progress. And this is a quote from this paper that was in the BMJ recently. The road to hell is paved with good intentions. The experience of applying for national data for linkage and suggestions for improvement. And this is really a paper that describes the difficulties and the severe barriers in being able to access data when you're trying to link a variety of different data sets. And it mirrors, I think, the experience that we have had in Leeds with a program grant from NIHR called Maestro. Now, the program lead for this program was Professor Alan House, who's retired over the last couple of years. But there are several people on this talk who participated in this program, including myself. Now, we're having to go back a number of years. It's at least, I think, 8 or 9 years when LP Maestro was first conceived. And we've been about 7 years in the process of trying to access the appropriate data, and eventually were unable to actually do so. But it was an attempt to link HES data and primary care data using Research One, and also additional linkages to mental health data sets, so to clinical trusts mental health data sets. And at the time, going back some years, this was quite novel. And this is a slide prepared by Dr. Chris Smith, one of our data scientists who worked on the project. that shows some of the processes involved, first of all, in just gaining approvals from various bodies, sponsors, ethics, CAG, etc., to gain access to the data. And he's put into this slide the number of timeline, the number of days between gaining these approvals. As you can see, some of them take over a year, or at least half a year, for you to get any kind of response. And this slide is actually a simplification of the processes that were actually involved, because many of these processes had to be repeated for a variety of reasons. If staff changed, you have to get new approvals. If certain approvals lapsed, you have to go back and get reapprovals for other approvals. So this is a simplified slide. And this next slide shows actually the processes involved in the data linkage. Again, this slide was developed by Chris Smith. Again, over nearly a year in some cases, in trying to basically link HES data with data from primary care. Now, this is just showing the problems involved in linking two data sets. This doesn't actually include any attempts to link with clinical data from mental health trusts. And we never even got to that phase in this study. So there are problems right across the board because people are not used to these kinds of systems. And these problems are some of the problems identified in the paper that I showed you, but also some of the problems that we encountered as well. So there are problems within your own educational institution in terms of levels of approval. There's no agreement for either side from different data controllers or departments. Many documents are designed with trials in mind and are difficult to complete if you're doing a different kind of design. Requests for alterations and further information from bodies is frequent, even though it's not specified at the outset. And there are annual renewals for each data sharing agreement, even though you apply for data for the life of the project. And because of this, it's very difficult to estimate costs. There are process delays, as I've illustrated by the diagrams. If you're working with HES, there are problems with the data dictionaries. So this means it's difficult to understand what data you need to collect. And even NHS digital staff are not aware of some of the idiosyncrasies. So to give you an example, we were trying to identify data sets via different hospitals rather than trusts, because trusts now kind of take over a large number of different hospitals. And the codes that we were recommended to use to identify a hospital didn't work. And we found out later, having gone through all the process of trying to apply for the data, that there are actually several different ways of coding hospitals that are inconsistent across the data. And the NHS digital staff were not really aware of this. As I've said, if you change a member of staff, all the data sharing agreements need to be updated, and once you've got approval, then the access to data takes a lot of time. There are difficulties also that I just want to flag up with reuse of data. So given that data is precious and it takes so long to actually get, once you've got it, of course, with the Data Protection Act, you can only use it for the purpose for which you've applied to use it. So even if another question comes up from a different, say, a linked set of researchers that your data set could answer, you can't use that data set. And in the paper that I quoted, they wanted to do this, and the permissions, in order to use the data that they had acquired to use for answering a supplementary question, took longer than 2 years to actually gain. So you use this very precious data. So to be brief, there are some areas that need to be addressed. The forms need, I think, to be specifically designed for purpose and not forms designed for RCTs. I think NIHR needs to be aware of longer timelines that can be built into research applications. So the usual timelines for research projects are 3 years, etc., can be very difficult if you've got to front load with getting access to data, and it takes such a long period of time. So it may be that research grants need to be allocated in different ways. So you get a tranche of money to start up to do all the data access and acquire the data, and then you actually move on to actually doing the research. A single application system for all data controllers would help to smooth things, and also consideration of ways that data could be reused, as it's a waste of public money. And it's also, it fails the public, because there are questions that we could answer that could physically help people's kind of outcome, but that data needs to be destroyed. We need the staff who are actually in NHS Digital and other centres that process clinical data to have some kind of research focus or research perspective, or at least some staff in those systems. It would help if there was a central authority for processing and improving applications. And also there are different models. We know now from COVID, there's the Oxford model, where you get linkage within the NHS system or within NHS digital, so you have to do the linkage outside the, that may be one. Then certainly in terms of mental health, the data is only so good as the data that's recorded on the actual systems. And at the moment, it may be different in physical health systems, but in mental health systems, there is no standardization really of data. All the electronic data systems are varied and different. They are really difficult to use by clinical staff. I personally have experience of 3 different mental health data systems, and they're all horrendous to use. And none of them record anything that is of particularly use to researchers. So an example is, I've never come across a mental health clinical data system that records medication accurately or records diagnosis. That you'd think those might be 2 things that might be of interest. So the granularity of mental health data is very poor. And when these set up, I don't know of any dialogue between clinicians and researchers about, you know, what could be genuinely collected by clinicians that would actually be genuinely useful for research. I'll stop sharing.